Yeah, we are live now. Good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar, a dynamic dialogue on fertility, myths and mythbuster in non-obstetric azoospermia, organized by Foxy Society Chennai and also A4 Hospitals and Fertility Center Chennai. So it's my privilege to introduce the moderators of today's webinar, Dr. Aruna Ashok ma'am. Ma'am is the fertility consultant and clinical director at A4 Fertility Center and Hospital. Ma'am has more than 17 plus years of experience and also mentor for fellowship reproductive medicine, A4 Fertility Center from 2022 onwards. And ma'am has been the faculty of FNB Reproductive Medicine, executive committee member of TAPISAR and OXY. I welcome you, ma'am. And it's my pleasure to introduce Dr. Aparna Das, ma'am. Ma'am has done fellowship in reproductive medicine at Sri Ramchandra Medical College and Research Center, Chennai, and also fellowship and diploma in minimal access surgery, Delhi, clinical lead at and a consultant obstetrics and gynecology and fertility specialist at A4 Fertility Center, Tambaram, member of ISAR, TAPISAR, Cox, Foxy, and ESHRE. Ma'am has presented poster in ESHRE and Amsterdam 2024 on subendometrial administration of agnigenic precursor cells and growth factors effectively optimizes endometrial thickness and pregnancy outcomes in women with refractory thin endometrium. So I welcome both the moderators and I hand over the session to them.
Thank you for the introduction, Seti. We can henceforth we can make it very short because every time they are here listening to our CV. So thank you for the introduction. I take privilege to welcome Dr. Sankalp Singh. Despite his busy schedule, he has accepted to be part of us for the academic journey, and we all know about him. So he is a director of YAMI Fertility and IVF Center, Indo. He is a former director of reproductive medicine unit of Kraft Hospital. He is he's invited in as a speaker in various national and international conferences and published original researches in peer-reviewed journals. Having special interest and actively involved in research pertaining to poor responders, recurrent implantation failures, and azoospermia. Mentored more than 120 fellows in reproductive medicine. He is known for his academic best teaching. So we have offered him the talk on azoospermia. So I think he's going to throw light on new avenues, what we should do, what are the protocols for non-obstructive azoospermia. It will be very useful for all the young specialists who are wanting to master this specialization. Though there is no end for updation. We'll just see what is the newer thing that Dr. Sankalp Singh is going to tell, or what is that we have to do. So over to you, and Doctor, welcome you. I have heard about so much of your academic lessons, but I've heard only one or two talks of yours. So I'm very happy to be inviting you. Over to Aparna Das and Sankalp Singh. Yeah.
Thank you, ma'am. Sir, could you share your screen, sir?
Yeah, sure.
Thank you, sir.
Is it visible now?
Yes, sir.
So shall I start?
Yeah, sir. Please.
Okay.
Yes, sir.
So firstly, thank you very much, Dr. Aruna, for inviting me for the talk to discuss about azoospermia. So today the topic would be about non-obstructive azoospermia, to discuss the myths and bust those myths which are there. So the focus of discussion would be a little bit about the basics of non-obstructive azoospermia, then busting the common myths which are associated. There are lots of myths which are associated with non-obstructive azoospermia, so some important ones I'll be discussing. a little bit about the procedural aspect of microdissection TSA, and then comparing microdissection TSA with other available modalities of surgical sperm retrieval, limitations of microdissection TSA, and what's the Indian data on microdissection. So, as we all know, the hypothalamus secretes the GnRH and it acts on the pituitary, leading to FSH-LH secretion, which then acts on the testis, on the Leydig and the Sertoli cells, and these basically govern the spermatogenesis. So, the whole pipeline starting from hypothalamus to Leydig Sertoli cells integrity is important, and these are all governed by its feedback loop. So if we see the normal spermatogenesis versus an obstructive azoospermia versus a non-obstructive azoospermia, so the normal testis, the red triangles are the areas where the spermatogenesis is there. So nearly in all the areas of the testis, we'll see spermatogenesis evidence. In obstructive azoospermia, also it is nearly the same, that all the areas would have spermatogenesis. So the chances of us getting sperm on surgical retrieval is 97 to 100%. In non-obstructive azoospermia, it depends on the histopathology, whether it's a hypospermatogenesis or whether it's the other two histopathology, which is maturation arrest and Sertoli cell only syndrome. So these are the three histopathologies which we can expect in a non-obstructive azoospermia. So if it's a hypospermatogenesis, as the name suggests, that the number of sites where the sperm production is happening is lesser than normal, but it is still there. So that's why 70 to 100% probability of us getting sperms. Whereas if it is a maturation arrest or a Sertoli cell only syndrome, then there are only one or two sites maximum where there might be sperm production, and other sites there might be no sperm production at all. So that's why the chance of retrieval of sperm in such cases is only 30 to 60%. Now, the last set, that is the maturation arrest and Sertoli cell only syndrome, are actually the main candidates who need help because many of them they don't want to go for a donor sperm. They want to have their own genetic child. And as a clinician, I feel it's our responsibility that we should give them whatever best possible modality of treatment so that they can have their own genetic child. Because many of them just give up hope because whatever center they visit, the clinician advise them to go for a donor sperm. Uh, what I feel is that the issue there is not the fact that we don't have the facility for it. It's just that we don't have will to do that, to will to counsel the patient, to sit with the patient, because these are the patients who take long time to counsel about the cost, about the procedure, about the success rate, and then we need to be ready to face them because as I have written there, 30% chance of sperm retrieval. So we need to face those 70% whom we will not get sperms at all. So it's a tricky business, but as a clinician, I think we have a responsibility towards them and we should try to fulfill it. So these are the myths which I'll be discussing. The first one being that the patients with NOA, they never have sperms in the ejaculate. The second is lesser the testicular size, lesser the success. The third is histopathological report of Sertoli cell only syndrome means sure short absence of sperms. Fourth is there is very low chance of sperm retrieval in Klinefelter syndrome. Fifth is varicocele has no effect on surgical sperm retrieval. Then the next is higher the FSH, there is no use of surgical sperm retrieval, just go for a donor IVF ICSI. Next is the only FSH level matters for predicting successful sperm retrieval and nothing else matters. And there is no advantage of doing genetic testing in non-obstructive azoospermia. The next is that testicular biopsy is mandatory before sperm retrieval. And if there is a failed TSA or TSA, then donor sperm is the only option. So these are the myths. Now let us discuss them one by one. So the first is that NOA don't never have sperm in the ejaculate. So the truth is that as many as 20% of NOA can have sperms in the ejaculate during the course of the treatment. Why that happens? It's because of something known as a spillover threshold. The spillover threshold means that every seminiferous tubule should be producing at least three sperms so that the back channel gets filled up completely and then the sperms are able to come out in the ejaculate. So we have 700 seminiferous tubules. So practically it needs 2100 sperms and above for the sperms to come out. Now, with medications or sometimes even without medications, non-obstructive azoospermia patient may have sperm in the ejaculate unless and until obviously they're having hypogonadotrophic hypogonadism. They cannot have it till they have injections. But hypergonadotropic patients can have sperm in the ejaculate, and it's not a bad ploy to check the sperms of in maybe every few months, even if we are more pro for going for say donor sperm because the patient is not able to afford a micro TISA or does not want to do a micro TISA. So as a policy, what we do is that even if there is a patient who's for surgical sperm retrieval other than obstructive azoospermia, we have a policy of checking for sperm in repeated samples and also on the morning of the sperm retrieval. So that in case we get sperms there and if they are adequate as per the number of oocytes expected, we can go ahead and use those sperms rather than doing a surgical sperm retrieval. The second myth is that lesser the testicular size, lesser the success of sperm retrieval. The truth is that there is no lower limit of testicular volume for the absence of spermatozoa. And Paul Devroy and colleagues long back in 1995 found that there is no statistically significant difference in testicular volume between patients who have retrieved versus whom we did not retrieve sperms. So smaller testicle, what it means is there is poor global spermatogenesis, but it does not mean that there is absent focal spermatogenesis. So there can be spermatogenesis in focal sites, not in all sites. So these are the patients and those are the areas which we need to target when we are trying to retrieve sperms for these patients. The myth is that the histopathological report of a Sertoli cell only syndrome means a sure shot absence of sperm. Now, the truth is that various studies they have shown that the SCO patients, Sertoli cell only syndrome patients can have 22 to 41% chances of sperm retrieval. Again, because only focal areas of the testis can have those sperm production happening in there. The next myth is that there is very low chance of surgical sperm retrieval in patients with Klinefelter syndrome. So I have had a lot of when we go to conferences, meet our colleagues, a lot of discussion happens regarding this, and many of us actually are of the view that in Klinefelter syndrome, we don't get sperms at all, or the second thing is myth is that if we take the sperm of the patient who has Klinefelter syndrome, the same defect would be transmitted to the baby as well. Those are the two very common myths related to the Klinefelter syndrome. So the truth on the contrary is that Klinefelter syndrome actually have one of the highest retrieval rates for the sperm. So this study showed that up to 40%, 65% chance of successful sperm retrieval was seen in patients with Klinefelter syndrome. And it was not a small study. It was around 155 patients were total seen. And importantly, all the children who were born were either 46XX or 46XY. So it straightway debunked that myth that if you use these sperms, the same genetic issue would be transmitted to the child as well. The next myth is that the varicocele has no effect on surgical sperm retrieval. So the truth is that the studies have shown more than 2 times increase in the sperm retrieval rates when you treat varicocele versus when you don't treat a varicocele. Now, what do guidelines say? What do international guidelines say? So if you see the American Urology Association and ASRM guideline, they gave the statement that the couple should be informed that there is absence of definitive evidence supporting varicocele repair before ART. So here the important thing to see is that absence of a definitive evidence. So there is an evidence, but it is not so well proven from RCT, which says that yes, you should do a varicocele repair. But if you see the European Association of Urology guideline, they say that varicocele repair may allow for return of sperm to the ejaculate in nearly 20 to 55% of men. And the repair of varicocele is associated with improved surgical sperm retrieval rate in cases if the sperm did not return in the ejaculate. And if you see one of the recent meta-analysis of 2024, again done in patient varicocele repair in patient with azoospermia, it again shows that there is a good chance of sperm retrieval if you repair a varicocele. So again, this is a good ploy to do, at least give a choice to the patient. The next and one of the very common myth is higher the FSH, there is no use of surgical sperm retrieval, and you should go for a donor ICSI. Now, whenever I see this FSH, one thing which it just crosses my mind is one of my very close friend when I was in Kerala is Dr. Raju Nair. And he is a very excellent clinician. He did from CMC Vellore. So long back in 2013-14, and I think one of the ACE conferences in Bangalore, I had a talk on micro-TSA, our experience, because we started doing micro-TSA in 2011. So 2013, I had a talk on that. So I had a discussion. We had a discussion there during the session that FSH, that time the highest FSH we got the sperm was 100, was 84. And he was shocked. And he came to me later and he said that Sankalp, I have done my fellowship FNB and I never knew that such thing also exists that with high FSH we can get it. So he told that even at 20 plus FSH, I was actually doing advising donor sperm for all the patient. And after that, he referred around 30 patients to me who had non-obstructive azoospermia for micro-TSA. So, I mean, that really says so much about him that he followed the ethics that yes, he doesn't do micro-TSA, but our center did micro-TSA. So instead of wasting, I mean, patients' precious time and with doing TSA and other things, he just used to refer that, okay, azoospermia, non-obstructive, you need a micro-TSA, please go there. So that's the story which I remember when I see the high FSH level. So the truth behind FSH, as beautifully studied by Dr. Ramaswamy and colleague from US, is they studied around 800 men and they studied various levels of FSH. And the chances of sperm retrieval, actually, if you see this particular bar diagram, it's higher when the FSH is 16, 31, and above 46 compared to less than 15. Okay. The reason for that is that FSH basically it is not just controlled by the factors from by GnRH, but estradiol level, inhibin level, testosterone level, all these control the FSH level. So due to this, the correlation between FSH and spermatogenesis is extremely vague because when a couple, when a male has a higher number of germ cell, like in maturation arrest, their FSH level would be more towards the normal side. But the probability of getting sperm in those patients would be very less because it's a maturation arrest. More often than not, even if you get sperm, those would not be good enough to be utilized for IVF ICSI process. Then, even if you analyze the predictors of sperm retrieval, then as you see in the second number, it's FSH, and the sensitivity varies from 9 to 71%, and specificity from 40 to 90%, which is extremely vague. And it just says that you should not rely on FSH to decide whether the sperm can be there in the testis or not. The next myth is that only FSH level matters for predicting successful surgical sperm retrieval. So there may be some therapeutic role of measuring testosterone and estradiol level and checking the T by E2 ratio. So there were two big studies done on this particular topic. One was by Peter Shalago and colleagues, 700 plus patient. So as per them, they optimize the testosterone level before doing the sperm retrieval. So as per them, whether the pre-treatment level was less than 300 nanogram per DL or more than 300, whether they treated or they did not treat, and whether the patient responded to the treatment or did not respond. Irrespective of that, their conclusion was none of them matters in the sperm retrieval. At the same time, in the same year, there was another study published, again 600 plus patients. and they in non-obstructive azoospermia, and they compared no medical treatment with the medical treatment. So whether they gave clomiphene or added HCG or added HMG also. So their target level, so this was the difference between the first and second study. They targeted that we want the FSH level to become 1.5 times of the basal FSH, which was there before the medications were started. And they targeted a testosterone level towards the higher side, that is 6 to 8 nanogram per ml. The normal level is more than 3 nanogram per ml or 300 mg per dl, but they targeted 6 to 8 nanogram. So what they found out was that irrespective of the final testosterone or the FSH level, whether the levels were increased or not increased, irrespective of the final treatment regime, whether you gave clomiphene or HCG or HMG, there was a significantly higher surgical sperm retrieval in the study group. This particular meta-analysis published in Human Reproduction 2022, where 22 studies were included with 1706 participants. Overall, a higher surgical sperm retrieval in subjects who were treated with hormone therapy was observed, with an odds ratio of nearly 2 times. Now, Aphrodite criteria. So if you see the group 3 in Aphrodite, group 4 in Aphrodite, it's basically non-obstructive azoospermia. So if you see the various groups of Aphrodite, whether it's hypo, reduced gonadotrophin, that is functional hypogonadism, biochemical hypogonadism, or the fourth one. So fourth is the one where you have a higher FSH levels, which includes the non-obstructive azoospermia patient. So they have advised HCG plus FSH to be given. Now, when I met Dr. Aruna recently in Bangalore, we were discussing about Aphrodite, and she asked me that, Dr. Sankar, do you follow Aphrodite criteria? Then I told her that I know that it is there, but I have my reservations towards it because and as per them, the first step is HCG and FSH. The problem is that most of the patients, they will not be too willing to take the injections. And secondly, most of them actually don't need injection to better their testosterone levels and increase the FSH. So if I say, if we are doing micro TISA in say 10 patients in a month, out of them, only maybe one or two would be needing FSH or HCG. Rest all the patients with clomiphene or tamoxifen plus letrozole, which is an excellent drug to increase the intratesticular testosterone. They respond beautifully, and I'm very happy with the micro TISA results. That's why Aphrodite criteria is there, but to use it in your clinical practice, it's little tricky because their advice is mainly based on the FSH and HCG as the initial treatment process. The next myth is that there is no advantage of doing genetic testing in non-obstructive azoospermia. So karyotyping and Y chromosome microdeletion are of extreme prognostic significance for surgical sperm retrieval. And 10 to 20% of NOA men would have a genetic abnormality. So it is mandatory as a rule for anybody whom we are suspecting non-obstructive azoospermia, we should not do any intervention, any medication. I don't give any medication or I don't do a diagnostic TISA unless and until I have done a Y chromosome microdeletion and karyotyping for that particular patient.
வாங்குறவங்க இருக்காங்க மேம், நீங்க குடுக்குறீங்கன்னு சொல்லி.
சார் என்ன சொன்னாரு அது
இல்ல
பண்ண
சார் நான் வந்து பார்க்கலாம்.
இப்ப அவரு பேபியோட போராடிட்டு இருக்காரு
Madam, I can
சார்
hear
போயிட்டு
your
இருக்காரு.
voice. Can you please mute the mic?
சார் எங்க இருக்காரு
மேல கீழ லேபர் ரூம்ல இருக்காங்க.
இப்ப எங்க இருக்காரு பேபியோட
மேல போறதா சொன்னாங்க.
Malat Selvi, ma'am. Madam, please could you mute your mic, ma'am?
Okay.
Thank
So, the next myth is that testicular biopsy is mandatory before surgical sperm retrieval. Now, with the testicular biopsy, I feel that there is less to gain and more to lose because the testicular biopsy tells about the predominant pattern of spermatogenesis. It does not give us any clue about focal spermatogenesis. And in 20% of patients, focal spermatogenesis would be missed after doing a unilateral biopsy. Now, the reason is that if this is the testis, if the triangle, the red triangle is the area where spermatogenesis is happening, we really don't know which area our needle is going because we cannot see that particular area. It's a blind procedure. So if our needle passes beside the area where the spermatogenesis was there, it will just tell us that there is no spermatogenesis. It will come as a SCO or a maturation arrest or any particular histopath which does not show us any sperm. So I don't feel that testicular biopsy is something which can help us guide the treatment plan. It may compromise the already limited sperm production in NOA by causing scarring in the testis and then by damaging the blood supply. So we should never do a testicular biopsy if the testicular volume is low. If the testicular volume is high, then still we might justify ourselves to do it. But wherever it is low volume, please never do a testicular biopsy. The accuracy of predicting a TC success, if we do a testicular biopsy, is 74 to 87% if we get at least one sperm in a random testicular biopsy. So what it says is that even if you get a sperm in biopsy, it does not tell you for sure that during your final procedure of, say, TISA, when you do, you would be able to get the sperms. So in such cases, if at all you're doing a testicular biopsy, you should always have the facility of freezing. If you get any sperm, you should have the facility of cryopreservation of those sperms so that you can use it later on in case the sperm number is adequate, or if the sperm number is less, still freeze it because you don't know if later on you don't get any sperm in the second sperm retrieval, at least the frozen ones can be used. So the BJU study which was done, it suggested that isolated diagnostic testicular biopsy is not recommended in men with NOA. The last myth is a failed TISA or a failed TISA or even a failed micro TISA means that you should do a donor sperm. Now, if you see the sperm retrieval rate in men who had previous TISA, so the orange one is where there was no previous biopsy. The surgical sperm retrieval was 56%. The middle one is where 1 to 2 biopsies were done from the testis. The sperm retrieval is 51%, and the last one is 3 to 4 biopsies. Still 23% of sperms were retrieved. So what it says is that again that doing a if one TISA fails, it does not mean that in a next TISA or next biopsy you cannot get the sperm. Repeat surgical sperm retrieval, if needed, it should be done only after 3 to 6 months. That is something important that you have done a TISA on one side, allow at least 3 months of healing. And if you have done a micro TISA on one side, allow at least 6 months of healing. I have at least 10 patients who had two micro TISAs. That is, in first micro TISA, we did not get sperms. And then in the second micro TISA, out of those 10, I think around 20 to 30, around 30% of the patients, we got sperms and we were able to use it for the ICSI process. What is the role of salvage or a repeat microdissection TSA? So the salvage TSA gives 45% chance when we don't get a sperm on, say, TISA or TC. That is, you are doing a TISA, you don't get a sperm, you convert it to microdissection TSA. Of course, you should have the facility, you should have the operating microscope for it, and then you'll have a good chance of getting sperm in case the TISA sample does not give you a sperm. So these are the various methods for sperm retrieval: PISA, TISA, or TSA. TSA can be single or multiple, and then there is micro TSA, which needs specialized equipment and operating microscope. And the advantage of that is you're able to see those areas where the sperm production is happening. So if you see that particular tubules which are dilated and yellowish and fluffy, and around that you can see the tubules which are very, very flat and which do not have sperms in it. So microdissection TSA results in higher rate of surgical sperm retrieval with lesser complications. It relies on identify the site of most advanced spermatogenesis rather than most predominant spermatogenesis. And that's what we were seeing in that picture where the red triangle shows that only 1 or 2 areas of spermatogenesis might be there in most difficult NOA patients. Then, if you see the differences between open TSA and microdissection TSA, so microdissection TSA needs an operative microscope, which has a magnification of around 16 to 25 times, which is very necessary because you can avoid damaging blood vessels and you can search for the area which gives you, which can increase your chance of getting sperm. Then the sperm retrieval chances is much higher. You tend to have more sample for cryopreservation. The problem is that it takes much longer time compared to a TISA or a TSA because you might need around 1 hour for each testis. But the tissue which you remove is extremely less. So in TSA, if you remove 50 to 720 milligram as per the previous studies, for micro TSA, it's only 5 to 10 mg because you're taking out only those tubules which are dilated and fluffy. Due to this, the vascular damage, hematoma formation, and post-op structural damage and scarring is extremely low in microdissection TSA when you compare it to TSA or TISA. Uh, Then, yeah, this was the study which showed the sperm, the tissue removal in microdissection TSA versus the conventional TSA. So, more than 10 times higher tissues are removed, the testicular tissue, normal testicular tissue, in a conventional open TSA compared to a microdissection TSA. So, ideally, the best method for surgical sperm retrieval should be the one which is a low cost OPD procedure, painless, minimal testicular tissue removed, higher recovery rate, no long-term testicular damage, and reproducible. And microdissection TSA ticks most of the boxes. Now, here when we do micro TSA in our center, we do it in the morning around 8 or 9 o'clock. And after 3 to 4 hours, patient is fit enough to travel back. So we don't even admit the patient overnight. They just come in the morning, do the procedure, and go back after 3 to 4 hours with perfectly fine walking without any issues at all. The limitations of microdissection TSA is higher cost, learning curve, longer duration of surgery, and extensive lab processing of the sample. The last part is extremely critical. You need to have very good embryologists, dedicated embryologists for the lab processing of the sample. Learning curve, if you see, so this was the study of 150 NOA done by a single surgeon. So the learning curve, it keeps as you do more number of cases that is go towards 150, your chances of sperm retrieval becomes higher. Operative time, if you see, usually 2 hours. If you get the sperm within 2 hours, there is 89% chance that when you do a micro T cell, 89% of the patient you will get the sperm within 2 hours of starting the process. Of the remaining 11%, you get it in 2 to 4 or 4 to 7 hours. The rest of the patients, it takes much longer time. So, as per policy, what we do is we do microdissection TSA 1 day prior. So, if the egg pickup is scheduled for tomorrow, we do the microdissection TSA today morning. We take the sperms out, we put it in the culture media, we put it in the incubator, and then we do the ICSI next day with the sample which is put in the incubator, and we have got excellent results. So this is the same thing which we are following right from 2011 onwards, that is since last 14 years. Our data, so we published 2 studies on microdissection TSA. These 2 studies were done. So what we have seen is that we've done around 1,590 total cases with around 50% surgical sperm retrieval. 49, we did not get the sperm. 43% of patients were able to reach till embryo transfer. 36% were beta positive. CPR was 29, and ongoing pregnancy or live birth rate was 26%, which I feel is pretty decent for a couple who thought that they don't have any chance of getting their own genetic child. So to conclude, microdissection TSA leads to increased surgical sperm retrieval with reduced complication. Repair of a coexisting varicocele might improve the surgical sperm retrieval. There is no sure shot predictor of successful sperm retrieval. And please do not rely on FSH as a marker to decide whether you can try or you should not be trying the sperm retrieval. Genetic testing of Y chromosome and karyotyping to be considered mandatory for NOA before doing any intervention. I even don't start any tablets before I do these testing. Further studies need to confirm the benefit of hormonal manipulation. Personally, what I feel is it helps and I follow it, but only thing is I don't give injections as the primary choice. I start with tablets in patients who have hypergonadotrophic hypogonadism. Only if the response to tablet is suboptimal, the testosterone level does not rise up, then I go for the injections. Sorry, microdissection TSA should be offered to cases with failed TISA or TSA. Cost and learning curve and dedication to give time are the main hindrances for the widespread use of microdissection TSA. Thank you for your patient hearing.
Thank you, sir, for enlightening us on so many topics. It is always a whatever myths you have told. It is, I think, for every clinician there is always a thing that doubt that whether to do or not do. And if suppose andrologist is not available, then as a gynecologist or infertility specialist who is not specializing in male fertility, it is little difficult to take decisions. But after your class, I think many doubts are cleared. I was going to ask the questions, but already you have answered regarding will you give hormonal injections or not, or hormonal evaluation, how it is going to help in your decision making. But already you have answered regarding that. It was a beautiful session, sir, and we have learned
Thank
so
you.
much after this. So I would like to ask regarding if suppose FSH, what is the correlation between FSH and the percentage of sperm what you get in micro TC? Is there any correlation like that?
Absolutely no correlation because the maximum FSH which we got till date it was 104. So that patient's FSH was 104, where we were able to successfully retrieve the sperms, and they got pregnant and delivered a child. And still those cryopreserved additional embryos are still in store. So I use FSH only to guide me whether the tablets, I check a basal level I check three things: FSH, LH, and testosterone. Then what I see is because I want the FSH and LH to go up and I want the testosterone to increase. So that's why I check the basal. Then I start the medication. So the most common medication which I start is I
So
start with
medication in the sense you don't give injections. Yeah.
no, I start with letrozole. So I start with letrozole. So I start with the alternate day letrozole. I also check along with the FSH I check a baseline LFT because with letrozole, if we get in continuity, there are reports of increase in the liver enzymes. But usually that liver enzyme does not cross 80. So usually it remains between 40 to 80, not for all patients, but for some patients. So then I start them on alternate day letrozole, 2.5 mg on alternate day, and then I add up also either a clomiphene or a tamoxifen. So clomiphene 50 milligram per day or tamoxifen 20 milligram twice daily. So these are the hormonal manipulation which I do. After a month, then I check the blood sample again. And in that, I check the FSH, and testosterone. And my aim is that testosterone should reach as close to 10 ng per ml as possible. Because the higher the testosterone, because what is important is previously it was thought that FSH and LH are the most important hormones for spermatogenesis. But then it was realized that it's not those hormones, it's the effect of those hormones in the testis which leads to increase in the intratesticular concentration of testosterone, which is critical. Now, the problem is we cannot measure intratesticular testosterone.
Yes.
So we need to then measure the serum testosterone. So serum testosterone gives us an indirect indication about how would be the intratesticular testosterone. So that's where letrozole comes into play, because with letrozole there is increase in intratesticular testosterone, which then spills over, comes to the blood, and then we are able to detect it in the blood. And that gives us the evidence that yes, since it has come into the blood and the main organ which produces it is the testis, that means the intratesticular testosterone would be in a good range for us to go ahead with the process. Now, once the level reaches a normal zone, then you need to wait for at least 2.5 months before doing the sperm retrieval or a semen analysis to check it, because 75 to 80 day is the cycle of the spermatogenesis. So once the level reaches a normal expected one, then the wait time is around 2.5 months.
Sir, what is your opinion on clomiphene citrate for men?
Clomiphene citrate is good. The only problem with clomiphene citrate is that in 10 to 20% of patient, it can cause erectile dysfunctions.
Mm.
So ED is in 10 to 20% of patients. So I usually tell the patient that you have a problem in erection, you feel something, you let us know. In that case, you might have to stop clomiphene. So now I continue with letrozole and stop clomiphene. Otherwise, clomiphene is good enough. The issue with clomiphene is that in some patients, it can actually alter the testosterone estradiol ratio because it can increase estradiol level more than the testosterone. So the ratio which we want T by E2 to be more than 10, it
10.
becomes less than 10.
Mm.
So that's the reason that we need to be a little careful when we are giving it. So I am if I have a choice of giving only one hormonal medication, my first choice would be letrozole.
So how long do you give
at
letrozole?
least at least 3 months minimum, and then I don't do sperm retrieval till at least 3 months of the hormonal medications are given.
Okay, so once 3 months is over, then wait for another 3 months and then do this.
No, 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 no. 3 months usually is adequate enough because once we start the hormonal medication, usually the serum level of testosterone becomes good within 2 to 3 weeks. Okay, so check it again in maybe 3 weeks' time. Once it has become normal, wait for another, say, 2.5 months and do the check the sperm count at that time after 2.5 months. And if there are no sperm, go ahead with the sperm retrieval.
So will anastrozole also works in similar way, sir?
Anastrozole also works. There are reports for that. We used anastrozole earlier, but I was not happy with the response which I used to get with anastrozole. So I stopped using anastrozole and I shifted to letrozole.
Okay, sir. So one of the doctors have asked any use if of letrozole if the T by A ratio is in normal range.
In that case, you have to check for what's the serum testosterone level that time. So so the normal serum testosterone is more than 3 nanogram per ml. So if it is say 5 nanogram per ml also in a non-obstructive azoospermia, I would want it to be in the upper side of normal limit. So
Okay.
that's why my aim would be for it to be near 8 nanogram per ml or 9 or 10 nanogram per ml, because that would increase the intratesticular concentration more. And because of that, the sperm production might be much better.
Okay, sir. So one of the doctors have asked any use of stem cell therapy in a way.
Uh, People have used testicular PRP, stem cell, and even now exosomes are being used. But the research is very divided for that, and there is no conclusive evidence of it having any beneficial effects. So I am not using it. We used it earlier for few patients, didn't find a benefit. But what I would suggest is whosoever wants to try it, please take a proper consent that it's an experimental therapy, because you don't know if there is any side effect from that. You might end up in a problem. And before doing that, make sure you do an ultrasound and rule out any possibility of a testicular tumor undiagnosed for that patient, because
Okay.
you don't want to fall into a problem that after 1 year he's diagnosed that okay, you have a testicular tumor, and then it is correlated, oh, you had an intratesticular stem cell, maybe that has given rise to a tumor. Then you will be in a problem. So it's an experimental therapy, so proper consent and ultrasound scan before doing it is mandatory.
So another doctor has asked treatment for severe morphological usually suggest for those patients.
So, out of the three things, that is sperm count, motility, and morphology, morphology is the least important of all the parameters as per the research, because Morphology, even if there are 100% abnormal sperm, still there can be a good chance of having even a natural pregnancy, not just IUI or IVF. So morphology, the only morphology, two morphologies which I am worried about is when there is globozoospermia, that is when all these sperms have round head, and the second is when all these sperm have pinheads, that is very small heads. Those are the two conditions which are very troubling. The problem is there is no medication which will improve it. So for globozoospermia, the only thing which can help is to do ICSI using calcium ionophore because it helps in egg activation. For pinhead sperm, usually the success rate is extremely poor, and you might have to go for donor eggs for them because it usually doesn't help in any way. There is nothing which helps in such cases. Other morphology, like some minor head defects, neck defects, tail defects, those are perfectly fine. I'm not too worried about them.
So another question they have asked is if FSH and testosterone are normal, and then you have gone for micro TC and you have found there are no sperms, then
Okay.
what?
Okay. So see, if so the thing is what I tell the patients is that with medications we are trying that if your cells have a potential to make the sperms, then we are trying to create an atmosphere where the sperm production can happen. But if your cells in the testis don't have the potential to make the sperm, then even if the environment is conducive, the sperms will not be made. So there is a so that's why the counseling becomes very critical in such patients. So then if we don't get the sperm, then usually we discuss beforehand because we start the patient's wife stimulation at the same time. So we make both of them ready at the same time. The reason for that is that sometimes in patients who need microtisa, the number of sperm which we get is very less. So when we freeze those sperms and then use it later on, more than 50% of sperm don't survive the freezing process. So then we might end up with not having adequate sperms to do the IVF. So then what we do is we stimulate the patient at the same time. We do the micro teaser a day prior, but beforehand itself, we counsel them that in case we don't get sperm, you have two options. One, I mean, three options practically. One is either you go ahead, you are if you're okay with donor sperm, we'll keep that as a standby ready. Second, if you don't want a donor sperm, but if you're okay with trying for another micro T cell later after 6 months, or maybe if something else comes up, if some evidence comes up that some stem cell or exosome therapy gives you can help in sperm production, then we can take the eggs out and freeze those eggs so that later on it can be utilized. And the third is to cancel the procedure completely. So the counseling regarding these three things, I do it beforehand itself, note it in the file so that it is clear to the patient, to us, and to the staff as to what needs to be done, whether we need to do the egg pickup and freeze the eggs or not.
Okay, sir. Sir, any new biomarker available to predict or evaluate spermatogenesis before SSR?
A lot of biomarkers are being studied. Like a recent study in 2024, they have gone through various genomic studies, tested more than 20 genes, different ones. They have gone through metabolomics and all kind of omics are being tested. But unfortunately, at this point of time, we don't have any biomarker which can help us. Even serum AMH is being used as one of the biomarkers, and 17-hydroxyprogesterone is also used as one of the biomarkers. But unfortunately, if you see the AMH studies, one study gives a different value, and another study says that the AMH should be different. So there is no proper cutoff to be taken with. So clinically important cutoffs, unfortunately, are not there to help us.
Okay, sir. Sir, if it is hypo, do you suggest any hormone? And if you do, what is the regimen you use?
In hypo, we have to go in a stepwise manner. That is, we know that the testosterone and I mean the clomiphene and letrozole are not going to work on the pituitary. So then, what we need to do is we need to use HCG and HMG. So firstly, we have to start with HCG because that patient, since there is no FSH and mostly LH and a very low testosterone, so we first want to increase the intratesticular testosterone production, which will then increase the FSH receptors in the testis, and then only that FSH would be able to act in the testis. So
Okay.
firstly, I give HCG, 5,000 units urinary HCG twice weekly for 3 months. I check the testosterone. Once the level rises by at least 1 unit or so, then I add up HMG and then continue this. So HMG, I give 150 units on alternate days, and I continue this for at least 1 year. And I counsel the patient beforehand that the treatment might take 1 to 2 years for the sperm production to happen. And many times we might get sperm production which is good enough for them to even try naturally, but only
Mm.
thing is that they'll have to continue taking injections.
Okay, sir. Sir, any experience on serum inhibin levels in male
1 year.
infertility?
2 years.
Yes, it was checked quite a lot, but unfortunately, serum inhibin has not been shown to have a correlation because, as I said earlier, the germ cell also can secrete the inhibin, which can inhibit the FSH level and bring it to a normal zone. So that's the reason that just checking the serum inhibin does not give us much value. So I don't check in serum inhibin levels.
So another question they have posted is, if sperm analysis is done and you see 1% motility, what should be your rescue plan?
The motility is the most difficult parameter to treat, unfortunately, because more often than not, the defective motility is related to the defective actin myosin and the fibrillin activities in the in the sperm tail. And those are mainly genetically determined. So I'll tell the patient that with medication, chances of sperm motility increasing is extremely rare. More often than not, we'll have to use these pumps, and then the only option would be to go for the IVF treatment. For IVF also, the problem is that with 1% motility, you basically don't have much sperm to choose from. So my protocol for this, which I follow, is that whenever the motility is low, I do a vitality testing because I want to see whether the sperms are alive or not. And if the vitality testing is good, then in that case, I tend to use pentoxifillin and laser treatment of the tail, laser stimulation of the tail, which helps me choose the sperm which are even totally immotile, but if they are morphologically fine and the tail moves on the laser shot, they are alive. So then I use them for the IVF. If suppose the morphology testing, the vitality testing also says that only 1%, only the motile sperms are the live one, which is extremely rare. In that case, I will use only those 1% which are live sperms. But in such cases, you should always use calcium ionophore for egg activation because when the motility is low, the problem is that the calcium signaling pathway of the sperm is defective. So even if the sperm reaches inside the egg, it is not able to activate the egg. So when the activation does not happen, the egg is not able to wake up from its sleep. So the embryo formation process does not kick in. So always use
Mm.
a calcium ionophore whenever you are using doing ICSI for patient with low sperm
Motility.
motility.
So regarding zero progressive motility, also you told that if
100%
the tail is
immotile,
twisted.
yeah, 100% immotile sperm, just do a vitality test. If vitality test is good, use pentoxifillin and use laser shot to the tail. Those two will help you recognize which are the live sperms and use them for IVF along with calcium ionophore.
Sir, Dr. Malar Selvi has asked, will you advise donor sperm option for Y chromosome microdeletion, even in SSR, if you could find sperm in view
So
of genetic transmission?
yes, so all the patients who we do the Y chromosome microdeletion. So if there are say 100 patients, 100 Indian men, if we do the Y chromosome microdeletion, 2% of them, that is 2 out of 100, we will get some sort of microdeletion in the Y chromosome testing, which might be A, B, C, or D. Now, A and B, there is 0% chance of getting sperm. C is the one which is in which we can get sperm. But in those cases, what we need to counsel the patient is that if you get a baby girl with your sperm, she will not have any problem. But if you get a baby boy with this sperm, the baby boy also would have the AZFC deletion. And that they have to keep in mind and they have to be ready. And then only we can proceed with the surgical sperm retrieval.
So in case of necrozoospermia, if suppose vitality test is there and nothing is good enough, how to proceed?
So you mean in vitality testing, there are no live sperms?
Yeah.
In that case, nothing can be done because you cannot use those sperms. Those are all dead sperms. So embryo will not form. Then you will have to use a donor sperm only.
What is the role of antioxidant in SORT patients?
So antioxidant mainly only helps in basically reducing the DNA damage to the sperm. That's the main thing which it helps. It does not actually help in the sperm production. So antioxidant can be given, but the if you see the evidence base, the literature is say does not have very good say evidence on that. But we all use antioxidant, but we should not be hoping that it will increase the sperm production. The only thing which it definitely can help you is in reducing the DNA damage to the sperm. But the problem is the DNA damage to the sperm is rampant these days because of all the environmental toxins which our body is exposed to, whether it is air pollution, water pollution, or the food pollution. Our all everything is contaminated. So for that part, I use vitamin D for all the patients and some or the other type of an antioxidant. You can use anything, vitamin C or vitamin E, all have basically a decent effect on the sperm DFI.
Sir, regarding the DFI, in some patients, when we are seeing for a patient day before yesterday, DFI we checked and it was 60. Prior to that, DFI was 67, and we gave antioxidants for 3 months and then rechecked because the patient was very irritated and was like, I want to really check it and then go for the next procedure. So we had to do it, but there was just only 7% decrease in DFI. So, what do you say about it, sir?
How much was the gap between the last ejaculation and the DFI testing?
1 day.
1 day. Okay. So see, and how was the morphology of the sperm?
Morphology
Morphological.
was 2%, sir, according to what they said.
Okay. What I would suggest is, was it done in an IVF center only, or the morphology was done
Yes,
somewhere
yes, sir.
else? It
No,
was
no,
done
I
in
guess.
IVF center. Okay. So see, it's extremely rare for DFI to be more than 40%. Usually what I see is mainly if the high DFI is there, it is less than 40. There are only certain patients where I have seen DFI crossing 50 or 60%, where you get into 91%, and those patients were the ones which had globozoospermia.
Mm.
Okay. So in literature also, globozoospermic patient have a tendency of having a higher DNA damage. So what my suggestion would be, get the sample evaluated by a senior embryologist to rule out any specific morphological abnormality.
Okay.
If it is not there, then check the sperm DFI using the second ejaculate on the same day in the gap of 1 to 2 hours. Okay. I hope you would have checked for all the other things like varicocele, smoking, and other things. All these things would be normal. There
Yeah,
is no infection.
yeah.
The semen culture is normal. Try changing the mode of the testing. If all these things are okay, do the testing with another method of checking the DNA damage because I have a doubt whether we are missing something or whether the report is incorrect. Because
Okay.
otherwise, it is extremely rare for the DFI to be so high.
Okay. So if at all you see a high DFI, then what is your protocol?
So, if there is a high DFI, say in a patient who is planning for a natural pregnancy or an IUI, lifestyle modification, which we just discussed about the avoiding all the mainly pollutants and diet-related advices. adding an antioxidant. So I usually add up a vitamin D and usually vitamin E and this coenzyme Q. These are the three things I add. And what I tell them is that when they come for IUI also, give the sample at shorter intervals. Okay. If the patient is affording to for their mental satisfaction, what you can also do is check the DFI in the second sample on the same day as what I said, because usually that sample would be much better and would have a lesser DFI. So similarly, if you're planning for a natural try or an IUI, tell them not to have too long abstinence between their trying whether it's natural or IUI. Even for IUI, the sample should be given in a very short interval of abstinence. If it is for IVF, then if the DFI is high, I we always use to ejaculate for all patients. So even if I don't do DFI, the standard protocol which we follow in here at Yami is that two samples have to be taken from all patient on the day of the ICSI, irrespective of their DFI. And we use then the second sample preferably because that is much fresher. So whosoever can give it, we all use two sample for all patients. It's a universal policy. Now, if the DFI is high, then the second sample you can use two things. You can use the microfluidics, which is the technique with which it filters out the sperm which have a bad DNA. And the second thing is you can use Pixie, that is physiological ICSI. Those Pixie dishes come and instead of a normal ICSI dish, you can use a Pixie dish. So those are the two things which we use. Now, which one to use a microfluidic, which one to use a Pixie, that I decide based on what is the count, what is the motility. Because for a
TISA for these patients.
we used to do TISA
For
earlier, doctor. Now
TISA
we
can be offered to this patient if they are really recurrent failure.
yes, it can be
We are not.
offered,
We are
but
also doing the Zymot or Pixie and 2 hours abstinence, but there are some literature and some centers who are doing TISA for patients who have repeated high DFI.
yes,
What do you call on that?
we did TISA for approximately nearly 100 patients and from 2015 to 17 for couples who had a high DFI, a decently poor history. And we compared the data with Zymot because that time Zymot was the only option which was left, and we didn't find any difference in the pregnancy rates. So that's why then I have stopped doing a TISA since last, say, 4 or 5 years since I shifted here. We have just stopped doing TISA as the primary thing. So what I do additionally is I counsel the patients and then I do a microfluidics before the IVF, that is before the actual sample with a shorter interval. I treat it with microfluidics, and then the sample which we get, we do the DFI in that to see how much difference this microfluidics has made from before to after, and then go ahead with the actual day with the same process. So Zymot, we have stopped using since last 1 year because with Zymot, the problem was that yield used to be less. So we started using that the lens hook, which is that CA0. So that is much better because it even with the lesser motility, lesser count, it gives a decent yield for us to use. Also, we do a second step in this for patients whom we are doing, say, this microfluidics. We use a second step also. That is, we use sperm mobile, which is hyaluronic acid, instead of a PVP for them. Because what hyaluronic acid does is, with lens soap, the motility increases. You get more motile sperms. Then, if you use a drop of this sperm mobile in it, that is hyaluronic acid, which comes, the hyaluronic acid would slow down the fast moving sperm and specifically slow down the ones which have a better DNA integrity. Then we pick those sperms and use it for the IVF process. So we combine the microfluidics and the hyaluronic acid. When we went to ISHRE this time, so there was a discussion that there is no study on this regard. There was a male infertility workshop which was there. And I think there are some studies which are ongoing in this, but I find it pretty logical that to use a two-step process rather than a single-step process if that can help us getting a better DNA integrity sperm.
The preparation time will not be too long if you're going to use a two-step method, because
No,
this
it
is a
is
direct microfluidics, not a DG and then you use it.
no,
So
direct
directly you do a
microfilm.
microfluidics and then you
Yes,
do a hyaluronic acid, you mix it. It is
yes.
not see you're telling. You're doing
No,
just a hyaluronic acid and then picking up the sperms.
it's no, yeah. Then no, if you are doing this, then no pixie. Pixie, we
Yes.
don't do it with this. So it's either this or pixie.
So this two-step method is very nice. What we thought for higher DFI patients is ejaculate in the morning and then come for the second sample. So
Hmm.
two samples instead of the, because the time is also delayed. So we asked them to ejaculate in the morning at home and then come and give another sample at the center. But not routinely we are doing double ejaculate. How does the patient complain, or they are fine with giving double ejaculate? There are no problem.
Perfectly fine, no problem. No problem.
Okay,
And the thing
nice,
is,
nice.
why I tell them to give it in the center is that there are, I would say, 5% of patient men who cannot give a second sample. So then the problem is then we don't have anything to back up our. So we take the first sample, we keep it in the warmer, we tell them to take the second sample. If they are able to take it, which is happens in 95%, we use that. If they are not, then we use the first sample.
Have you analyzed the results of semen freezing and ICSI samples and fresh samples? Have you had a analysis for
Yeah,
yourself?
yeah. We did
Does semen
actually.
freeze?
It's pretty good. The only problem is that we should not be doing it in couples who have previous failed IVF or miscarriages. The reason being that the freezing itself increases the DFI.
Yes.
So that is something which we should be. I don't prefer. But otherwise, for frozen TISA sample,
So,
frozen
how
micro
many
TISA
percentage of
samples, we
your
are
IVF
very happy.
cycles you do ICSI? Yes. Sorry, I
Sorry, the
interrupted you.
voice got cut in between.
No, we wanted to know if there is 100 patients for whom you're doing ICSI, how many patients you will be subjecting them just a DG density gradient preparation, how many of them you will do microfluidics, how many of them you will do PIXI, how many of them you will do IMSI. So what is the proportion?
IMSI, I don't do. I don't. I'm not convinced with IMSI. Regarding usage of the Pixie versus the lens hook, I would say it's. I mean, the microfluidics. It is say out of 100, it will be 30, 30, 40. That means 40 patients would be when we don't use any of these. We just, if everything is good, we just go ahead with the density gradient and use it. The majority of them who are able to do a DFI, actually, unfortunately, these days DFI comes high for most of the people because of all the effect, even if they don't smoke. So due to that, we use say 30% we use Pixie, 30% we use the microfluidics, again based on the fact that what's a count and what's a motility, and accordingly decide which one to use.
Nice. So
So
patient-friendly.
we actually did a comparative analysis of doing this what I just told you, that is lens hook plus the that microfluidics plus sperm mobile, and we compared it with Pixie. So what we did was we for around 12 to 13 patients where the egg numbers were good and they were for PGT. So we did half oocytes with this, half oocytes with this, and we did PGT and to find out how many are euploid, and euploidy rate was same in both the groups. Uh, and there is actually no
Okay.
research published on that, but we just did it our in-house to convince ourselves that the things what we are doing is working.
Nice. You can. I think they have more questions. Yeah.
Okay.
So varicocele treatment, what is your take on that surgery?
Uh, it's very difficult because the patient usually does not want to undergo surgery. If the patient is okay to undergo surgery, it's a very good thing, provided there is a clinical varicocele, not an ultrasound diagnosed varicocele. So, clinical grade 3 varicoceles, I always recommend them for treatment, but most of them they say that, doctor, I am okay with even IVF, but I don't want to get the surgery done. Can we manage with the IVF and medication? In that case, I check a DFI and use the various things to reduce the DNA damage and do the IVF.
So, Dr. Indumati wants to know what is the cause of necrosospermia and is there any way to prevent it?
The commonest cause of necrozoospermia is actually an undiagnosed infection. Whether it's an infection which is coming from the urinary tract or from the reproductive organs, the infection is the commonest cause. The second commonest cause of necrozoospermia is when the collecting bottle which where the sample is collected is not compliant with the regulations which is needed for the gametes. So try checking for that. So we do semen culture for all the patients, whether they are for IVF or not, so that we can treat it. Because if there is infection, which we call it as Maggie, that is the male accessory genital organ infection, then the probability of even natural pregnancy goes down. So we do check it for everybody. So those two are the commonest thing which is there. Unfortunately, if it is not due to any of these two causes, then there is nothing else which can be done if there is no vitality. If vitality also gives a 0% result.
So, thank you so much. It's almost 5:20 now. We are beyond our
My
time.
pleasure.
Thank you for clearing our doubts. It was a beautiful session.
My pleasure.
Thank you,
Thank you.
Sheel.
Thank you very much. Thank you very much for the invite. Okay, then. Bye bye. Take care.
Thank you.